Okay, in this chapter we're going to be talking about adolescents' psychosocial development. In terms of psychosocial development, if we return to Erikson's theory, his stage that takes place during adolescence, or I should say the primary stage of adolescence, and also in Erikson's view and many others, one of the most important stages, and certainly one that Erikson spent the most amount of time discussing. That's identity versus role confusion. This is Erikson's term for the fifth stage of development, in which the person tries to figure out who am I, but is confused as to which of many possible roles to adopt. And interestingly enough, there's a lot of evidence to suggest that Erikson himself struggled quite a bit in terms of this role confusion of figuring out the process of who am I, and it's certainly one that many people can relate to, because at some point, the great majority of us, we don't know exactly who we are or who we want to be, or ultimately who we'll choose to become to be. And typically school, and in college in particular, is a place where a lot of adolescents are able to figure that out. So identity, we could define it as a consistent or one's self, one's one's sense of self, that is, as a unique individual in terms of roles, attitudes, beliefs, and aspirations. And the term identity achievement refers to the attainment of identity, or the point at which a person understands who or she is, who he or she is, as a unique individual in accord with past experiences and future plans. So if you decide, for instance, one example of identity achievement might be, you start off college not knowing anything about what you might want to major in, but you take a few introductory classes, and then you discover that you might like to pursue the field of psychology and become a clinical psychologist. Of course, it's typically not quite that easy for the majority of people, and so role confusion, or identity diffusion, it might also be referred to as, a situation in which an adolescent does not seem to know, or perhaps to care, what his or her identity is. And in particular, when people are in this state of role confusion, or have not really identified who they're going to become, there's a couple of different options that adolescents seem to take. One of those options is foreclosure. This was Erikson's term for premature identity formation, which occurs when an adolescent adopts parents' or society's roles and values wholesale without questioning or analysis. So if you decided to go into a particular area of study simply because that's what your parents and their parents before them had done, that would be an example of foreclosure. Moratorium, on the other hand, is an adolescent's choice of a socially acceptable way to postpone making identity achievement decisions. So going to college is a common example, and I've known several students who actually prolonged their graduation just in order to stay in college a little bit longer because they really didn't know what they wanted to do. So that's a good example of an individual who might be in the moratorium. There are, I guess we could say, about four areas, or four major areas of identity achievement. There could certainly be more than that, but four major areas, and these vary across time and places, of course. So they're somewhat culturally dependent as well as time dependent. But one is religious identity, and religion may or may not be a large part of any individual person's identity. But even one who chooses not to be religious is sort of choosing an identity there. Gender identity, this is a person's acceptance of the roles and behaviors that society associates with the biological categories of male and female. And related to the concept of gender identity is also someone's sexual orientation. Now, they're not exactly the same. One could have one gender identity, and that doesn't necessarily determine what their sexual orientation is, but typically the two are associated with one another. Sexual orientation is a term that refers to whether a person is sexually or romantically attracted to others of the same sex, the opposite sex, or both sexes. There's also political or ethnic identity. And then finally, there's vocational identity. And vocational identity is rarely achieved until at age 25 for at least four reasons. One is that few teenagers can find meaningful work. In other words, I remember the jobs that I had taken as a teenager were jobs like dishwasher, working as a prep cook in a kitchen, working as a waiter, the types of things that I didn't I didn't think I was going to necessarily do for the rest of my life, but those were things that were sort of holding me over until I could obtain a better position. It takes years to acquire the skills needed for many of the careers, and so it's often premature to select a vocation at age 16 because, again, you really don't have any of the tools that ultimately will be needed 10 years later in order to perform certain jobs. And that's particularly so the case for jobs that might require advanced degrees like becoming a doctor or a lawyer, where you have to go to both undergraduate school and then for postgraduate education as well. Most jobs are unlike those of a generation ago, so it's unwise for youth to foreclose on a vocation. In other words, it's not it's not as easy to choose a particular vocation that may have been the same as one of your parents or grandparents, because the nature of jobs themselves are changing quite a bit. And also, most jobs are in the service or knowledge sectors of the economy, and to be employable, of course, adolescents spend years mastering literacy, logic, technology, and human relations. So this is certainly a time when there is an increase in the number of day-to-day conflicts that adolescents have with their parents. Parent-adolescent conflict typically peaks in early adolescence and is actually more of a sign of attachment rather than distance. Most of this conflict, it can be considered bickering. That is, it's just petty, peevish arguing, usually repeated and ongoing, although not necessarily about critical topics. Things like you shouldn't be wearing this, or you shouldn't be getting your ears pierced, or something like that. Neglect, on the other hand, although teenagers may act as if they no longer need their parents, neglect can be very destructive, and they're still very much in need of parental figures, even though adolescence is a time when children are first trying to distance themselves in order to become more autonomous. And in terms of closeness within the family, there are some different things that we could look at that are characteristic of the degree of closeness that adolescents have with their children. First, do parents and teens talk openly with one another? So how well are they communicating? How well do they rely on one another? That gets at the idea of support. How emotionally close are they? And do parents encourage or limit adolescent autonomy? And again, autonomy refers to an individual's ability to be in control of themselves, rather than, certainly young children, they do the things that their parents dictate them to do. But as we get older, we become more and more autonomous. And adolescents are certainly more dependent on their parents in some respects, particularly if they are female and or from a minority ethnic group. So again, there's going to be some cultural variability here, ethnic variability, and also some sex differences. And this can either be repressive or healthy, depending on the culture and the specific circumstances. And this could be particularly tricky if it's the norm for one culture to be rather repressive during adolescence, or at least for children to be dependent upon their parents in adolescence, particularly if they are recent immigrants and find themselves in a culture where it's not quite as much the norm to be so emotionally dependent on one's parents. And parental monitoring, this remains a very important aspect of adolescent growth and development. Parents we could define parental monitoring as parents' ongoing awareness of what their children are doing, where, and with whom. There are positive consequences of parental monitoring when it's part of a warm, supportive relationship. In other words, asking questions to an adolescent child about where they're going and what they're doing and things like that, for the sake of knowing, rather than for the purpose of scrutinizing everything that they do. That's seen as being more of the overly restrictive and controlling type, which tends to have a negative outcome. And of course, the worst is psychological control, which is a disciplinary technique in which parents make a child feel guilty and impose gratefulness by threatening to withdraw love and support. Peer support becomes more and more important throughout adolescence. Beginning at age 12, it's certainly important, but not nearly as important as it may be, during the later teens. And there are two different ways that we could characterize the types of peers that adolescents have. One is a clique. This is a group of adolescents that's made up of close friends who are loyal to one another while excluding outsiders. It's much more narrowly defined than a crowd. A crowd is a larger group of adolescents who have something in common but are not necessarily friends. In other words, outsiders may see them as being part of the same group, but they themselves may not necessarily consider themselves the same group, and that consideration is by the outsider is primarily based on again, some characteristic that they may share in common, although they're not necessarily friends. Peer pressure becomes quite a bit greater during adolescence, and peer pressure is the encouragement to conform to one's friends or contemporaries in behavior, dress, and attitude. It's usually considered a negative force, as when adolescent peers encourage one another to defy authority. However, it's not always going to be the case that it's negative. Peer pressure could also be positive. Getting a friend, for instance, to join an after-school activity could also be considered a form of peer pressure. In terms of how teenagers seem to go about choosing their friends, selection refers to the fact that teenagers tend to select their friends whose values and interests they share, while abandoning friends who follow other paths. So again, we become a little bit more choosy in terms of who we're friends with during adolescence. Facilitation. Peers both facilitate destructive and constructive behaviors in one another. So again, that peer pressure could be either positive or negative. It could be destructive or constructive. It makes it easier to do both the right thing, like let's all skip school together, and the wrong thing, as well as the right thing, such as let's study together. And it helps individuals do things that they would be unlikely to do on their own. Sometimes destructive peer support in the form of deviancy training occurs when one person shows another how to rebel against authority or social norms. In terms of sexuality, children move from being asexual, that is, not particularly involved in having sexual relations or having sexual thoughts of that nature, to becoming quite active. And there's a relatively well-characterized sequence of male-female relationships during childhood and adolescence. First, you have groups of friends that are exclusively one sex or the other. Then after that, there becomes a loose association of girls and boys with public interactions within a crowd. And so again, these are transitions that take place across the adolescence age frame. And then you have small mixed sex groups of advanced members of the crowd, and then you get formation of couples with private intimacies. Straight romantic relationships, these first romances tend to appear in high school, but they rarely last more than a year. I'm sure that we can all remember relationships that we may have had that at the time seemed like they were going to last forever, perhaps, only to die out after just a few months, perhaps. Girls claim a steady partner more often than boys do, and breakups and unreciprocated crushes are relatively common. Adolescents tend to be crushed by rejection and sometimes contemplate revenge or suicide. And you can imagine that the level of heartbreak that they experience, that's tied in with their ability to regulate their own emotions. For individuals who who identify themselves as gay, many do not acknowledge their sexual orientation. National and pure cultures often make the homosexual young person feel ashamed. Many gay youth date members of the other sex in order to hide their true orientation. And past cohorts of gay youth had higher rates of clinical depression, drug abuse, and suicide than did their heterosexual peers. The true number of homosexual, heterosexual, and bisexual or asexual youth is unknown, although it does appear quite strongly that heterosexual is by far the most common. Although, whether these represent actual categories that are discrete from one another or more of a continuum of sexuality ranging from same sex on the one side to bisexual in the middle to heterosexual on the other side, is also a possibility. In terms of sex education, peers do a great deal of learning from one another. Adolescent sexual behavior is strongly influenced by peers. The specifics of peer education depend on the group. All members of a clique may be virgins or all may be sexually active. And in some groups, they take, particularly church-based crowds, they take a virginity pledge. That is, if a group considers itself a select minority, then they might go ahead and take this virginity pledge to not have sex until some later date, typically when they get married, or past the age of 18. Only about half of U.S. adolescent couples discuss issues such as pregnancy and sexually transmitted infections, and many are unable to come to a shared conclusion based on accurate information. There is some learning that may occur from parents, although parents often underestimate their adolescents' need for information. Many parents know little about their adolescent sexual activity and wait to talk about sex until their child is already in a romantic relationship. Gender and age, they tend to be the most significant correlates of parent-child conversations. In other words, parents are more likely to talk about sex to daughters than to sons, and they're more likely to talk to older adolescents over the age of 15 than to younger ones. So parents tend to underestimate adolescents' capacity to engage in responsible sex. Proper condom use actually is higher among adolescents than it is among adults. And parental example may be more important than actual conversation about sex. In terms of learning about sex in school, there have been different attempts to try to include certain types of education programs. One type of program was the abstinence-only program. In 1998, the U.S. government decided to spend about $1 billion over 10 years to promote abstinence-only sex education to public schools. The goal, of course, was to prevent teen pregnancy and STIs by waiting until marriage before becoming sexually active. Although no other information about other methods of avoiding pregnancy and infection was provided, and it turned out that the abstinence-only curriculum had very little effect. The most effective programs, in contrast to the abstinence-only type of program, begin before high school. They include assignments that require parent-child communication. They focus on behavior and not just conveying information. They provide medical referrals on request, and they last for years. And it's important that school programs, they do make a difference, even though that abstinence-only program was not shown to be effective, that's not to say that there's nothing that can be done within the school itself. These factors here seem to be the most critical in terms of determining whether or not a particular school program will be effective at accomplishing the goals of encouraging adolescents to have safe sex. As an example, in 2007, more than half of all U.S. teenagers had had sexual intercourse by age 16. The rate of teenage pregnancy in the United States has declined dramatically since 1960, although it still remains higher than any other developed nation because of American teenagers' use of less likely to be using contraception. 86% of new teenage mothers are unmarried, and about 20% of teenage couples use the pill and condoms to prevent both pregnancy and infection. So certainly some teens are using contraceptive methods and engaging in safe sex, although certainly not all of them. This graph shows the percentage of both boys and girls, and also the total that have answered yes to the question, have you had sexual intercourse? So you can see that in the 9th grade, it's just over 30%. And by the 12th grade, it's just over about 60% total, where boys actually had outnumbered girls up until the 12th grade. In 12th grade, that's the only year, at least from this particular data set, this is the only year that girls were actually somewhat higher in answering that question affirmatively than boys were. But you can see that there's a relatively linear increase across each year and grade. So again, it's important to start before high school because by 9th grade you can see that greater than 1/3 of children are already having sexual intercourse. Another area of concern is depression in adolescence. So self-esteem for boys and girls takes a dip at puberty. Okay, it's at one of the lowest times in all of their lives, and this is particularly so the case coming from early childhood when self-esteem is much less likely to be an issue. And signs of depression are actually very common. The 2007 Youth Risk Behavior Survey of 9th to 12th graders showed that 36% of girls and 21% of boys experienced depressive symptoms within the past year. So keep in mind that those are depressive symptoms, not necessarily clinical depression. Clinical depression is really a more extreme version of your typical depressive symptoms, but they generally include things like feelings of hopelessness, lethargy, and worthlessness that last at least 2 weeks or more. That's one of the defining characteristics of clinical depression, is that it's got to have that at least that 2-week time frame, and it also has to include a number of different symptoms. It can't just be 2 or 3. Gender differences, interestingly, start to appear in depression during adolescence. This was not the case prior to adolescence. It was relatively equally distributed among males and females. But 20% of female and 10% of male teenagers experience a level of depression that would meet diagnostic criteria for major depressive disorder. The cause for gender disparity, it may be biological. It may have something to do with hormones. It may have something to do with genetics. It may be psychological. That is, it could be just the way that that males and females think about events that could potentially lead to depression, or it could be social. In other words, it could be that females are more subjected to the types of things that would lead to a depression. One explanation is the cognitive explanation, that is that teenagers are more likely, and in particular female teenagers, are more likely to engage in rumination, which is repeatedly thinking and talking about past experiences, particularly negative ones, and this can contribute to depression and is, again, more common in females and girls. Of course, one of the worst possible outcomes associated with depression is suicidal ideation or suicide attempts, really. There's a difference between suicidal ideation, which is really just thinking about suicide, and suicide attempt, which is actually attempting to carry out suicide. So suicidal ideation, thinking about suicide, usually with some serious emotional and intellectual or cognitive overtones. Adolescent suicidal ideation is very common, although completed suicides are not nearly as common. And adolescents are actually less likely to kill themselves than adults are, even though they are more likely to think about it. They're less likely to actually kill themselves or commit suicide. There are a number of common misconceptions about suicide as it relates to adolescents. First, and there are four reasons, or perhaps more, that these misconceptions are held. One is that the suicide rate for adolescents, as low as it is higher than it was in the early 1960s. Second, statistics on youth often include emerging adulthood. So emerging adulthood is actually seen as being separate from adolescence. It's again an even newer term. Adolescence, the idea of adolescence hasn't been around forever. It's relatively recent, but even more recent is emerging adulthood. And many statistics on suicide in adolescents include that age group of emerging adults who are older than adolescents. So that sort of makes it look like it's actually higher than it is. Also, adolescent suicides capture lots of media attention. The more media attention there is on a topic, the more common we associate it. And suicide attempts are relatively common in adolescents. Again, attempts, but not necessarily carrying through and actually completing a suicide. So what we can see in this chart here is that there's actually been, in terms of suicides per 100,000 in each age group, we see that a very small proportion of 10 to 14-year-olds are attempting suicide, but that number really increases between the ages of 10 to 14 and 20 to 24, and then it's relatively stable, although it differs from year to year. In 1962, there was a pretty gradual increase that continued almost to the end of the lifespan. Although more recently, in 1980 and even in 2005, the data have been a little bit flatter in terms of the increase in likelihood. But what we do see is that it's at its highest for the most part during late adulthood. One thing that parents and other adults and even adolescents themselves should be aware of is are cluster suicides. These are suicides that occur when several suicides are committed by members of a group within a brief period of time. In other words, if somebody close to an adolescent commits suicide, other adolescents, within that group, are actually at somewhat of an increased risk of committing suicide themselves. And parasuicide is any potentially lethal action against the self that does not result in death. And parasuicide is common. Completed suicide is not. So it's much more common for people to cut themselves rather than to actually cut themselves to the point where they actually die from it. And when we look at completed suicide risk factors, risk increases for the completion of suicide with the availability of guns, with the use of alcohol and other drugs, with a lack of parental supervision, and in a culture that condones suicide. Now you may be wondering, what cultures would possibly condone suicide? Well, there may not be any that specifically say, this is a viable strategy for getting out of your problems, but certainly in some cultures there's more or less stigma against it. There are also some gender differences in suicide. The suicide rate among male teenagers in the U.S. is 4 times higher than the rate for female teenagers. Now, interestingly enough, even though female teenagers may be attempting more often, male teenagers are actually completing far more often. As you can see, 4 times as often. The reasons for this difference, and this is also a difference that's seen between males and females in adulthood as well, the reason for this difference has to do with the availability of lethal means. So the male culture tends to shame those who attempt suicide but fail. Males tend to shoot themselves, females tend to swallow pills or hang themselves. Swallowing pills is a timed a process that takes time, and if you take just a few too few, then it's not going to result in death. But using a much more lethal method like a gun is much more likely to end in death, and there's no turning back after someone has pulled the trigger. So girls, they also tend to let their friends and families know that they're depressed, but boys do not. So in other words, females can be brought to the attention of others, and that risk can be assessed more frequently than it can with boys. Some adolescents self-medicate with drugs and alcohol, and again, this actually has the effect of potentially increasing the risk of suicide. And decreased rates of adolescent suicide in the United States have occurred because of antidepressants. Even though some antidepressants, for example Prozac, may increase suicidal ideation, it's saved more lives than the number of lives that may have been lost due to an increase in suicidal ideation. And again, keep in mind here the difference between suicidal ideation and suicide attempts, and also suicide completions. That relieving depression is more likely to reduce the risk of suicide relative to the potential side effect of those medications, which includes an increase in suicidal ideation. Increased anger during puberty is normal to some extent, but most adolescents express their anger in acceptable ways. Steady aggression throughout childhood and adolescence is typically a warning sign, and in those who have higher levels of anger and aggression, are at a greater risk of becoming juvenile delinquents. These are individuals who are under the age of 18 who break the law. That's the definition of a juvenile delinquent. They're also at a risk for, and then of course, juvenile delinquents are at an increased risk of becoming life course persistent offenders. These are individuals whose criminal activity typically begins in early adolescence and continues throughout life. In other words, they sort of become career criminals. Alternatively, some juvenile delinquents will also be considered just adolescence-limited offenders. These are individuals whose criminal activity stops by the age of 21. And so, adolescent-limited offenders, that's a much it's actually a better outcome than the life course persistent offender, even though we'd ideally like to eliminate criminal activity altogether in adolescence. Drug use becomes more widespread from age 10 to 25, and then decreases after the age of 25. Drug use before age 18 is the best predictor of later drug use. There are age differences. There are also national differences. Nations have markedly different rates of adolescent drug use. Even nations with common boundaries can be quite different from one another in terms of drug use among teens. And these variations are partly due to differing laws the world over, but of course they're also due to cultural differences in drug use. We also see some cohort differences. Drug use among adolescents has decreased in the U.S. since 1976. The adolescent culture may have a greater effect on drug taking than laws do. Most adolescents in the U.S. have experimented with drug use and say that they could find illegal drugs if they tried. Most U.S. adolescents are not regular drug users, and about 20% never use any drugs. And once again, drug use differs from nation to nation and also varies from state to state. In terms of some of the different types of drug use that are more common, we can see that cocaine, one of the more dangerous drugs, has one of the lowest prevalence rates of use. The same thing with amphetamines, whereas cigarettes have one of the highest, only behind alcohol, which in this data set was only measured from the year about 1992 on. But cigarettes, marijuana, and alcohol, we can see, are by far the most common. Although other drugs, other illicit drugs, not marijuana though, are also at a relatively high rate of use, hovering around 10%, between these different age periods here, years rather. There are some gender differences in drug use as well. Adolescent boys generally use more drugs and use them more often than females do. And these gender differences may be reinforced by social constructions about what constitutes proper male and female behavior. For example, in some cultures, males hold the belief that if I don't smoke, I'm not a real man. Okay, and so if females don't share that same social stigma, then they're going to be less likely to use drugs. In terms of harm from drugs, tobacco we saw was just about the most widely used, only behind alcohol perhaps. It slows down growth, can even impair digestion, nutrition, and appetite, and particularly it reduces the appetite. It can even cause protein and vitamin deficiencies, and it can also damage developing lungs, hearts, brains, and reproductive systems. Generally speaking, the younger one is when they use tobacco, and the more the more they still have left to develop, the greater the impact that tobacco is going to be. Alcohol we saw was one of the most frequently used drugs or abused drugs among North American teenagers. This would be considered abuse if for no other reason than these are individuals who are illegally using it. That is, it's illegal to use it before the age of 21. Heavy drinking may permanently impair memory and self-control by damaging structures in our brain, such as the hippocampus and the prefrontal cortex. And again, this is really heavy drinking that shows clear signs of damage. But if we extrapolate from what heavy drinking does, we can sort of make the inference that even moderate levels have some effect on our hippocampi and the prefrontal cortex. Alcohol, it's probably one of the most widely abused because it's a momentary or a temporary form of relief, and it can result in denial of problems. When problems get worse because they've been ignored, more alcohol may be used in order to compensate for the increased severity of problems that they have as a result of either their alcohol abuse or denying the problems that are leading to alcohol abuse. And denial itself can have serious consequences, particularly if an individual continues to use and abuse alcohol despite the negative health effects that it's having. Adolescents who regularly smoke marijuana are more likely to drop out of school, more likely to become teenage parents, and more likely to be unemployed. While not uncontroversial, marijuana does have an effect on memory, also language proficiency and motivation. And there's a dose response curve here where the higher the dosage or the longer continued use of a particular dosage of marijuana, the more likely that these problems in cognitive functioning are likely to be to manifest. Occasional use of any drug occurs, but drug use is often progressive, and the first use usually occurs as part of a social gathering. Few adolescent drug users are addicts, but occasional drug use can lead to addiction. The younger a person is when beginning drug use, the more likely addiction will occur. And occasional drug use excites the limbic system and can interfere with our prefrontal cortex. So drug users are oftentimes, as a result, more emotional and less reflective in their behavior. How do we try to prevent drug use among adolescents? Well, one of the barriers to this is generational forgetting. The idea that each new generation forgets what the previous generation had learned. That is, even though our parents can say, I shouldn't have done this, I shouldn't have used that drug when I was in high school or college. It's as if the next generation doesn't benefit from any of the previous mistakes that have been made. And that's typically not the case with many other things. As used here, the term refers to knowledge about the harm that drugs can do. Project DARE, this is something that many individuals are familiar with. I went through the DARE program myself. It features adults, usually police officers, telling students about the dangers of drugs, although as much effort, time, and money were spent on this DARE program, it really has been shown to have virtually very little impact on later drug use. In other words, the program, despite the best attempts, was not shown to be effective. What else is not effective? Scare tactics. Okay, in fact, they may actually increase drug use because the advertisements make drugs seem exciting sometimes. Adolescents also, they recognize the exaggeration that adults may be trying to make this look worse than it actually is, and they often do. So adolescents recognize this, and also the ads give some teenagers ideas about ways to show defiance. Advertising campaigns against teen smoking, such as anti-smoking announcements produced by cigarette companies, can also result in actually an increase in use. What's important is that prevention and moderation of adolescent drug use and abuse are possible, and that the anti-drug programs, sort of like the sex education programs we talked about before, and messages, they need to be carefully designed in order to avoid a backlash or generational forgetting.